session on antithrombotic hot issues in ACS-PCI. So the first speaker will be Dr. Cohen, and the title of his presentation is Contemporary Best Antiplatelet Strategy in HBr or CHIP Patients, How and What?
Thank you very much, Dr. Palmerini. It's a pleasure to be here. This is an interesting topic. I used to know everything about antiplatelet therapy, and it's just gotten more and more complicated to remember. So every once in a while, to give a talk like this is helpful for me to refresh my memory about all of these things. So this is my interventional cardiology career on one slide. Really all of the history of DAPT after PCI and stenting. Nobody in this room is probably old enough to remember, maybe Dr. Kim, maybe, when we did bare metal stents and we had no DAPT. Then in the late 1990s, we introduced 1 month of DAPT after the ISAR and STARS trials. Drug-eluting stents came out in the early 2000s, and at that point, we were recommending 3 to 6 months data of DAPT, but with no data behind that whatsoever. Then there were lots of concerns about late thromboses in 2007, which led to changes in practice, again with no evidence whatsoever, of 12 months of DAPT. And then finally, we started to have evidence in the early 2000s, 2014, the DAPT trial, which showed a trade-off between thrombotic and bleeding complications, and the mantra became to individualize. And so I want to now talk just about 3 issues relative to what I think is optimal DAPT in 2024. I want to talk about whether the DAPT trial is still relevant. I'm going to talk about high bleeding risk patients because that's what I was asked to do, and then complex PCI patients, which overlaps a little bit with D.W. Park's talk later, but I'll give you my brief opinion on that. So is the DAPT trial still relevant? It's actually a very interesting question, and I think the authors of this paper, many of whom were principals in the DAPT trial, that tried to take the data from the DAPT trial and see what it would translate into if it was done in modern practice. And so what they used is data from the U.S. Cath PCI registry that has virtually all of the PCIs in the United States from fairly recent time, 2016, 2017, and then they re-estimated the treatment effects in the DAPT trial based on the distribution of characteristics in the current registry. And what they found, interestingly, is that the main results of the DAPT trial were actually no longer present. The benefit of 30-month versus 12-month DAPT on stent thrombosis, MACE, and myocardial infarction was greatly attenuated and was no longer statistically significant, but there was still a predicted increased risk of bleeding with prolonged DAPT. And the authors speculated quite a bit on why that might be the case, and I think it's relevant. One of the main factors was better drug-eluting stents. All drug-eluting stents we use now are second generation, and most of the ones in the DAPT trial were first generation. Patients are getting older, a little bit sicker. There's more high bleeding risk patients being treated in 2024. And then the second, I think, really important factor is the introduction and proliferation of the stronger, more potent P2Y12 inhibitors, and many of our contemporary studies that I'm going to be sharing with you have used ticagrelor. And then finally, we're using different strategies for DAPT discontinuation. In the DAPT trial, it was basically aspirin. That was the default strategy if you weren't getting DAPT. And now there are a number of studies that I'll be discussing talking about P2Y12 inhibitor monotherapy. The one thing that still does hold up from the original DAPT trial is the DAPT score. It still does segregate patients into those in whom there is net benefit versus net harm with longer DAPT. So what is the optimal DAPT regimen in high bleeding risk patients in 2024? Well, to understand that, I think you go back, again, a fair number of years to the original West trial, the first study really that said we can get rid of aspirin. As many of you, I'm sure, remember, this was about a 600-patient trial of patients who had an indication for long-term oral anticoagulation. They were all taking, again, there were no, DOACs were not really being used very much at this point, so it was all warfarin. And they were randomized after their PCI to oral anticoagulants, aspirin and clopidogrel, versus double therapy, just aspirin, just clopidogrel and OAC. And the durations were based on the current practice at that time. The primary endpoint was any bleeding, and the secondary endpoint was ischemic complications. It was not a surprise that getting rid of the aspirin cut the bleeding rate by more than half. What was a surprise, though, was it also cut the rate of ischemic complications, including mortality, which was really a shocker and led to, I think, what has been a really remarkable transformation of our field and of our thinking about doing research, and what are the real questions to answer, because again, this really set the stage for stopping aspirin. This has now been extended into a large number of studies. One that I was involved in quite a bit was the Twilight trial that Dr. Mehran led, which took about 9,000 high-risk PCI patients, either high risk for bleeding, high risk for ischemia, or both. After 3 months of open-label ticagrelor and aspirin, then they were randomized double-blind to ticagrelor plus aspirin or ticagrelor plus placebo and treated for an additional 12 months. And the primary endpoint, again, showed a significant reduction, almost a halving of the risk of bleeding by getting rid of the aspirin, and no difference whatsoever with respect to death, MI, or stroke. And now this has been replicated in many, many different studies. This is a meta-analysis from a couple of years ago of 7 randomized trials of P2Y12 monotherapy after PCI. You can see a number of them used ticagrelor, 1 used clopidogrel, and then there were several that were sort of all comers. And even in the few years since that's been done, there are two more trials that are not reflected in this analysis that would be supportive of it: the TPAS trial from Korea and the Ultimate DAPT trial that was just presented from China, both using ticagrelor. And what a meta-analysis of those first 7 trials, or 6 trials in this case, showed was significant reductions once again in bleeding with no difference in death, MI, or stroke. You can see the pooled estimate is actually in favor of getting rid of the aspirin in this case, after a variable amount of time ranging from 1 month to as much as 6 months, depending on the patient population. Those trials included high bleeding risk patients, but weren't exclusive to high bleeding risk patients. This trial here, the Master DAPT trial, was an exclusive high bleeding risk population, almost 4,600 patients randomized to 1 month of DAPT with agent of choice, followed by P2Y12 monotherapy versus a minimum of 3 months of DAPT, depending on the coronary syndrome that the patients had. You can see the median duration here was basically 1 month versus 6 months. And importantly, about half of the patients in the monotherapy group received clopidogrel, the easiest to use, the easiest to access of these drugs. The primary endpoint was a quadruple composite, including both ischemic and endpoints, as well as major bleeding. And then these are the components of it. So again, as we've seen in virtually all of these studies, no difference really to speak of with respect to ischemic endpoints and a substantial reduction in major bleeding. The event rates on both of these are substantially higher than what's been seen in many of the other trials, showing that our high bleeding risk patients tend to also be at high risk for ischemia as well. One interesting question that has been recently addressed in a very interesting meta-analysis is the question of whether it's better to stop the aspirin or to stop the P2Y12 inhibitor. I just showed you a whole bunch of trials that were stopping the aspirin, but another option would be to stop the P2Y12 inhibitor. This is a network meta-analysis of 19 studies, 73,000 patients, looking specifically, in this case, at whether it was better, if you're going to stop one, which was better to stop. You can see here that all of these point estimates for a variety of ischemic endpoints as well as major bleeding are all either even or to the right of the line favoring stopping the P2Y12 inhibitor. The only one that differed significantly, though, was myocardial infarction. But why I really liked that study is it had this really cool figure in it, which is the Bayesian analysis of this. And it shows the 3 different arms that were being compared: DAPT, for an extended period of time, P2Y12 monotherapy or aspirin, stopping P2Y12 monotherapy or aspirin monotherapy after stopping the short DAPT. And what you can see, depending on the shade of the green, that was where it was more favored. And you can see basically P2Y12 monotherapy is pretty much the favored therapy for each of these different components, including major bleeding, all the different ischemic complications, many of the times being favored in more than 80 or 90% of the simulation. So again, I just thought that was a really great way of depicting the results. Finally, let me just talk briefly about optimal DAPT in complex patients. For a long period of time, we have believed, and we had some evidence to suggest, that complex patients really need extended DAPT. This is a meta-analysis by Gennaro Giustino, where they really defined complex features and complex lesion PCI based on all these different features, and showed, again, the more features that were present, the more likely you were to benefit from extended DAPT. But then more recently, there's been an individual patient data meta-analysis, 5 trials of short DAPT with P2Y12 monotherapy, and they looked specifically at the complex PCI subgroup using the same definition. And what they saw here was with respect to bleeding, again, always lower bleeding by stopping the aspirin, but again, a trend, not a statistically significant trend, but a trend in favor of stopping the aspirin with respect to ischemic complications, even in these complex lesions. And if you look at the relationship between the number of complex criteria and whether P2Y12 inhibitor was better with respect to ischemic complications, you can see, again, none of them are statistically significant, but again, if anything, the trend is favoring P2Y12 monotherapy. The more criteria you have, the stronger the signal is. So to finish up, DAPT after PCI continues to represent a trade-off between ischemic protection and bleeding, and individualized therapy does remain still a key to optimizing the risk-benefit profile. But over the last decade, there have been numerous studies that suggest that P2Y12 monotherapy may be a key to uncoupling, finally, that ischemic protection from bleeding risk, and this is especially the case with potent P2Y12 inhibition. Based on the data I've presented, I would say that accumulating data suggests that for both high bleeding risk patients as well as for complex PCI procedures, 1 to 3 months of DAPT followed by P2Y12 monotherapy can reduce bleeding without an increase in ischemic events, finally something that gives us a free lunch. The benefits here are clearest with ticagrelor. It's been the most studied. And for patients treated with clopidogrel, I think we do still have to think about whether there's whether we should do genotyping or platelet function testing to make sure they are getting something effective before we stop the aspirin, especially if they're treated in the ACS setting. Thanks very much. Moderator, Dr. Tullio Palmerini from Italy, who's going to speak about escalating or de-escalating an ACS PCI.
Thank you. So de-escalation and escalation antiplatelet therapy are 2 ways of modulating antiplatelet therapy in order to balance the risk of ischemic events versus bleeding events. By de-escalation antiplatelet therapy, we mean decrease in intensity of platelet inhibition, which can be achieved by switching to a less potent drug, by reducing the dose, or by discontinuation of therapy. By escalation, in contrast, we mean increase in intensity of platelet inhibition. This can be achieved by switching to a more potent antiplatelet drug, increasing the dose, or adding on a standard antiplatelet therapy. And this can be applied both to dual antiplatelet therapy and single antiplatelet therapy. Escalation antiplatelet therapy, why, in which patient, and how? The rationale of escalation antiplatelet therapy is to reduce the risk of ischemic events with no trade-off with bleeding. And the optimal candidate for this kind of escalation therapy would be the patient with stable coronary artery disease at increased risk of thrombotic event. How can we achieve escalation antiplatelet therapy? There are 2 ways: unguided therapy or guided therapy by platelet function or genetic testing. Among the various modalities of implementing escalation antiplatelet therapy, switching to a more potent drug is the most investigated one. So we can have a patient on dual antiplatelet therapy with aspirin and clopidogrel, and we escalate to aspirin plus prasugrel or ticagrelor, or we have a patient on single antiplatelet therapy, aspirin or clopidogrel, and we escalate to prasugrel or ticagrelor. But from a practical point of view, we will concentrate only on patients on double antiplatelet therapy because this is the most investigated issue. Definition, very important. There are 2 definitions. If we take the literal definition, we mean by escalation of dual antiplatelet therapy a period of DAPT with clopidogrel plus aspirin, followed at some point by a more intensive regimen. So we start with ASA plus clopidogrel, and at some point we give ASA plus prasugrel or ticagrelor. But there is no reason to implement a strategy like that. So this is just a theoretical scenario. The broader definition would imply intensification of dual antiplatelet therapy upfront compared to what it would be the default strategy. So we have a patient, a stable patient on aspirin and clopidogrel, and we decide to give him aspirin plus prasugrel or ticagrelor up front, and the clinical context would be that of a patient with stable coronary artery disease, a tight thrombotic risk, and low bleeding risk. So we have two trials of unguided escalation antiplatelet therapy, Alpheus trials, almost 2,000 patients, ticagrelor versus clopidogrel, Sassicaia trial, almost 1,000 patients, prasugrel 60 milligram loading dose versus clopidogrel 600 milligram loading dose. There are both negative. So at the moment, there are no data that suggest that escalation antiplatelet therapy, unguided escalation antiplatelet therapy, is of any benefit. Escalation-guided antiplatelet therapy can be achieved by two-way platelet function testing and genetic testing, according to which if we have high on-treatment platelet reactivity or CYP2C19 loss of function allele, we switch to aspirin plus prasugrel or ticagrelor up front. So we have two trials that use platelet function testing, Arctic and Trigger PCI. They were both negative. How is that possible? There's no doubt that high home treatment platelet reactivity is a predictor of stent thrombosis and myocardial infarction. And these are the data of the DAPT, the largest study that has investigated this issue. But now look at patients with no stent thrombosis. There is a large number of patients with high on-treatment platelet reactivity with no events. Stated in more elegant way, the positive predictive value of platelet function testing is very low, 1.2% for stent thrombosis and 3.8% for myocardial infarction. And with such low values, low positive predictive values, designing a randomized trial would imply enrolling a large number of patients. What about genetic testing? We have only one such trial. It's the Taylor PCI trial, which randomized 5,000 patients to either genotype-guided therapy or conventional therapy. But of these patients, only those with loss of function allele were analyzed. So we have 900 patients with loss of function allele treated with ticagrelor and 946 patients loss of function allele patients treated with clopidogrel. Again, results were not different between conventional therapy and genotype-guided therapy. So there is a secondary analysis done on cumulative events, which turned out to be significant for the ischemic endpoint. But look at this number, 82% of patients had acute coronary syndrome. And now you are comparing an experimental arm versus a standard arm of clopidogrel plus aspirin, which is not the gold standard in patients with acute coronary syndrome. De-escalation antiplatelet therapy, again, two definitions, a period of dual antiplatelet therapy with prasugrel plus ticagrelor, followed by a less intensive regimen. So we start with ASA plus prasugrel and ticagrelor, and at that point we switch to ASA plus clopidogrel or to ticagrelor monotherapy. And then we have a broader definition in which depotentiation of dual antiplatelet therapy will be performed up front compared to the default strategy. So we have a patient which should be treated according to guidelines. So it is a patient with acute coronary syndrome with ASA plus prasugrel or ticagrelor, and up front, based on genetic studies or platelet function studies, we give ASA plus clopidogrel. But are genetic studies truly the escalation randomized trial? We have three such trials, popular genetic, Taylor PCI, Pharmaclaw. And the experimental arm, let's concentrate for a moment in the experimental arm. It's done of patients who are carriers of loss of function allele, which are given potent dual antiplatelet therapy, and non-carrier, which are given clopidogrel. But now we know that the polymorphism, the genetic polymorphism for CYP2C19 is responsible only for a minority of the variability on of platelet responsiveness to clopidogrel. In these studies, 5%. There are other factors that are responsible for the variability in platelet responsiveness to clopidogrel, which are age, diabetes, platelet count, and interaction. There are also studies that have refuted an association between the genetic makeup and ischemic event, and this is the largest meta-analysis performed so far, which show no association between a patient with the loss of function allele of CP2C19 gene and ischemic outcomes. So these are events in patients with acute coronary syndrome according to the time. And we know that ischemic events are higher in the first period, let's say within 1 to 3 months. And now we want to be sure that in this period we give the best therapy for patients with acute coronary syndrome, which is undoubtedly the combination of aspirin plus ticagrelor and prasugrel. But we are not sure that if we give clopidogrel, even in patients who are not carrier of loss of function allele, we are giving to this patient the same benefit. So this is the rationale because we performed this meta-analysis, which was based on 3 main points. So we define de-escalation antiplatelet therapy as a brief period of potent dual antiplatelet therapy, followed by depotentiated antiplatelet regimen. So we selected only those trials in which patients were given prasugrel or ticagrelor plus aspirin for the first 1 to 3 months. So this is a criterion to exclude genetic studies. We consider only acute coronary syndrome patients treated with this regimen because only in this patient prasugrel and ticagrelor have been shown to reduce the risk of ischemic event. And we consider de-escalation as switching to depotentiated dual antiplatelet therapy or ticagrelor monotherapy because there are enough data that clopidogrel monotherapy in patients with acute coronary syndrome after 3 months is not enough. So with this criteria, we select 6 randomized trials, and we performed a meta-analysis of 20,000 patients and a network meta-analysis comparing de-escalation strategy each other. The primary endpoint was all-cause mortality. And you see that at 1 year, de-escalation therapy was associated with a reduction in the risk of mortality, which is probably was due to a reduction in major bleeding and not paying a price in terms of ischemic events. And these data are consistent with the recently published randomized trial, Ultimate DAPT, in which, again, it was a double-blind, placebo-controlled randomized trial with 3,400 patients with acute coronary syndromes. And again, patients in the ticagrelor plus aspirin group had increased rates of bleeding compared to patients in the ticagrelor plus placebo group, and there was no difference in the risk of MACE. So in conclusion, in patients with acute coronary syndrome undergoing PCI, the escalation antiplatelet therapy defined as a brief period of potent dual antiplatelet therapy followed by depotentiated DAPT or ticagrelor monotherapy is associated with the reduced rates of major bleeding, probably mortality, with no trade-off with ischemic events compared with standard potent DAPT. Despite the need of a tailored approach for balancing ischemic and bleeding risk and the strong rationale for escalation antiplatelet therapy in specific clinical contexts, more data are needed for a broader implementation of this strategy. Thank you.
Thank you very much. So now we're going to transition from the acute phase to the chronic phase, and Professor H.S. Kim is going to speak to us on long-term antiplatelet management beyond the first year.
For the next 10 minutes, I'd like to briefly touch the long-term antiplatelet therapy beyond 1 year after PCI or ACS. Many years ago, there are meta-analysis supporting aspirin as a choice of monotherapy to prevent the cardiovascular event as a primary as well as a secondary. Here, non-fatal myocardial infarction is significantly reduced by aspirin monotherapy than no medication. But there is one previous clinical trial, randomized clinical trial, such as CAPRI trial, to compare aspirin versus clopidogrel monotherapy in patients with atherosclerotic vascular disease. We can see the clopidogrel was better than aspirin. especially in patients subgroup of prior history of infarction or stroke. The difference is the largest. But this study does not use a PCI as a high dose in statin, and at that time aspirin was 325 milligrams. Thus, several years ago, guidelines of monotherapy for secondary prevention after PCI was aspirin. Clopidogrel was only an alternative strategy. Thus, we started the host exam trial because there was no definite evidence comparing aspirin versus clopidogrel monotherapy after PCI in chronic phase. Thus, we enrolled more than 5,500 patients who were event-free under DAPT for 1 year and randomized them into either aspirin versus clopidogrel monotherapy for 2 years, and we checked primary endpoint, including all death, infarction, stroke, recurrent ACS, and major bleeding, BARC type 3 or 5. This is primary outcome of aspirin and clopidogrel. 7.7, 5.7% for 2 years. Risk difference is about 2%, NNT, 50 patients. How about the secondary endpoint? Thrombotic endpoint as well as bleeding endpoint was better with clopidogrel. The risk reduction was over 30%. Then we did a subgroup analysis. All subgroups favor clopidogrel monotherapy than aspirin. I'd like to select several subgroups to present you the results. First, DM subgroup analysis was performed. About 40% of this cohort was diabetic. The result is shown here. The difference primary endpoint was wider in diabetic subgroup than non-diabetic subgroup. Of course, both subgroups reached statistical significance. Thus, clopidogrel was even better than aspirin, even in diabetic subgroup. Here is secondary events such as thrombotic endpoint in diabetic and non-diabetic, bleeding endpoint in diabetic and non-diabetic. The absolute risk difference was 1.78% favoring clopidogrel. Here is 1.66%. Thus, in diabetic subgroup, the benefit of clopidogrel was more dramatic in terms of thrombotic endpoint. How about bleeding endpoint? In DM, non-DM subgroup, absolute risk difference was about 1.36% in DM, 0.72% in non-DM. Of course, bleeding benefit of clopidogrel was over. Aspirin is more prominent in diabetic subgroup. Thus, if you meet diabetic subgroup, you have to remember clopidogrel rather than aspirin in chronic maintenance therapy. The other subgroup is ACS subgroup. About 60% of this cohort presented as ACS at the index PCI. Here is the absolute risk reduction and risk number with clopidogrel compared to aspirin. In thrombotic endpoint, in ACS group, absolute risk reduction reaches about 4% with clopidogrel than aspirin. In non-ACS group, that was about 3%. Thus, benefit of clopidogrel regarding thrombotic endpoint is more dramatic in ACS group. How about bleeding endpoint? The risk reduction was about 1% with clopidogrel over aspirin in ACS, 3% in non-ACS. Thus, bleeding benefit of clopidogrel was more prominent in non-ACS patients. Another subgroup analysis is regarding risk score. Most of patients, we could retrieve the TIMI risk score for secondary prevention, TRS-2P, as well as DAPT score. In this cohort, as TRS-2P increases, primary endpoint, thrombotic endpoint, bleeding endpoint all increases because TRS-2P reflects clinical risk profile. In terms of DAPT score, as it goes high, thrombotic endpoint increases while bleeding endpoint decreases. Thus, this score is well validated in our host exam 5,000 cohort. The results is shown here. High TRS-2P group, low TRS-2P group, high low DAPT group. All the groups support clopidogrel than aspirin, but most significant difference was observed in high TRS2P group, suggesting benefit of clopidogrel was more prominent in patients with high clinical risk. Of course, there is significant difference in low TRS2 group and high DAPT and low DAPT score. The risk reduction with clopidogrel was more dramatic in high DAPT score group than low DAPT score group. Here's another presentation of this analysis. High TRS2P reflects highest clinical risk profile. In that group, we can achieve the most gain with clopidogrel over aspirin. When we plot these four cohorts, depending on the major bleeding risk as well as thrombotic composite endpoint, favoring clopidogrel versus aspirin, all groups located in this sector, suggesting clopidogrel was better than aspirin, not only in reducing bleeding, but also in composite thrombotic endpoint. The most dramatic group was high TRS2P group. Interesting finding is thrombotic endpoint reduction with clopidogrel was consistent across four groups, while bleeding benefit is a little bit different, highest in high TRS2P and low in low TRS2P score. In 2 years results, the most important thing was different mortality. Here, 19 versus 14 cardiac death, 32, 22 non-cardiac death. Of course, it did not reach significance, but this is lifetime medication that we have to solve this issue. Hypothesis is a result of by chance, or it may some significance. That's the reason why we pursue the follow-up duration up to 6 years after randomization. About 87% of patients meet per protocol analysis. The result is shown here. Primary endpoint until 6 years was 17 versus 13% in aspirin clopidogrel. Risk difference was exactly the same as 4%. NNT decreased down to 24 patients. Here's landmark analysis at 2 years. Beyond 2 years, the curves diverges consistently. All subgroup analysis favors clopidogrel for 6 years. Here's secondary endpoint. Thrombotic endpoint and bleeding endpoint was different. Clopidogrel reduced the thrombotic endpoint by more than 30% for 6 years, bleeding endpoint by more than 25% for 6 years. Bleeding severity and site is very interesting. Type 2 bleeding is not different between two groups. Type 3 bleeding was different. Bleeding site is also very interesting. GI bleeding is, of course, different, but most dramatic difference was intracranial bleeding. Happened 0.5% in clopidogrel, 1% in aspirin. Mortality issue resolved when we continued the follow-up up to 6 years, 6.2% versus 6.0%. We participate in Panther meta-analysis to answer which monotherapy is best for secondary prevention, including 7 RCTs, 4 employed clopidogrel, 3 ticagrelor versus aspirin. Here's primary efficacy outpoint, including CV death, infarction, stroke, was better with PY inhibitor. Hazard ratio is about 88%. Bleeding is also better with PI inhibitor. Hazard ratio is 87%. Of course, it is mainly driven by clopidogrel trial. NACE was better with PI inhibitor. Hazard ratio is about 89%. Thus, in conclusion, long-term antiplatelet therapy beyond 1 year after PCI or ACS is at least clopidogrel is better than aspirin in every subgroup, especially in diabetic or patients with high clinical risk. Thank you very much for your attention.
Thank you, Dr. Kim. So the next speaker is Dr. Duk-Woo Park. The title of his presentation is DAPT Duration in Complex PCI, Unsettled or Already Established Issues.
Thank you, Tullio. So my topic is about the DAPT duration in contemporary PCI practice and the unsettled or case closed question. So this is my disclosure. So I'm gonna start the complex case presentation, and the 63 male and presented unstable angina, and he had multiple risk factor and diabetic more than 20 years, hypertension more than 20 years, hyperlipidemia, and concurrent smoker, and 1 packs daily. And looking at the coronary angiography and spiral view, and the SUC disease, very severe disease, and the high diagonal is ramus branch is a significant disease, and the disease is also involving the distal limb main and the prox LAD disease. So we did IBUS evaluation. Is almost all case, complex case. We do imaging guided PCI. This is showing the left main, the shaft is plaque burden is huge, and the minimal lumen area is less than 3.5. We decide to the full coverage from the mid LAD to the left main ostium, as well as a complex PCI distal left main bifurcation region involving ramus branch and the circumterritory. So, and the final the result is looks good, excellent, and we did double crush stenting, LAD diagonal, big diagonal, and left main circumflex. We put the 5 drug-eluting stent, left main LAD 2 stent, SUC 2 stent, diagonal branch 1 stent, and these patients underwent 5 drug-eluting stent. We guess how long we should do dual antiplatelet therapy for these patients. This is a real representative case of the CHIP procedure case, and this is, I think, unsettled question. Optimal duration, 6 months, 1 year, 2 years, or more. So, and roughly DAPT duration in US and the EU guideline, mainly based on initial presentation, ACS versus stable angina, also HBR status, and they recommended 6 months or 1 year. So, and the DAPT duration and the roughly settled, but in the real practice, the scenario is very diverse. Such a recommendation is based on the historical key random trial in the world, and this is a keystone of the history of the DAPT trial. Also, as shown in the Professor H.S. Kim, and in Asian population, we conducted many trials regarding DAPT duration and the escalation and the de-escalation and different the method, antithrombotic strategy. We did a lot of clinical RCT, and recently published the important trial starting De-Escalate, the New England Journal of Medicine, and the host exam published in the Lancet Journal. So, and the trend of duration of the trial is, as shown in the Tullio, and the escalation, de-escalation is now is essential part is booming, and the key modulatory part duration of the DAPT, and the potence, P2I12 inhibition, and the omission of aspirin. So in the real world practice, as shown in my case, there are many diverse risk factor, and for requiring escalation, for requiring de-escalation. Everybody know well HBR, high bleeding risk category. Also, by contrast point, and some patients showing the very higher ischemic risk and STEMI and stent thrombosis history, diabetics, and the CKD, and the many anatomical complex cases like left main and diffuse bifurcation region, CTO region, severe calcified region, and multivessel disease. That is the main region, and the optimal duration, the antithrombotic therapy is very complex. So, and over the last 2 decades, there are many clinical trials done. It's about the escalation trial, high ischemic risk, and the Pegasus, Themis, Compass, and recently host exam trial evaluation is a more potent clopidogrel compared to less potent aspirin monotherapy. And the de-escalation, the short depth or P2I12 monotherapy, many trials recently done, Global Leader, Smart Choice, and Twilight, TICO, and the Talos. And recently, the last TCT meeting in the TPAS trial also published, and the P2I12 inhibitor monotherapy would be good, and the short depth would be okay. So for targeting HBR patient, and the short depth trial was until recently published in important journal, and the Master Depth, Senior, Onyx, and the last year ESC meeting Fireflow, the depth trial, short depth would be okay for HBR patient. So, and on the basis of such cumulative RCT duration of depth, and this is the most updated guideline, the last year ACC AHA guideline, and the complex and the strong recommendation, class 1 recommendation in the stable coronary angina patient, and aspirin should be done, and the depth is depending on the breathing complication, and the 6 months or the 12 months we can do, and such a very escalation, de-escalation diverse strategy, and the still class 2A, the recommendation, and the P2I12 monotherapy also, and the class 2A, the recommendation. So, and the last year ESC meeting, and some updated ACS, the antithrombotic, the guideline, and this guideline, they introduce abbreviation depth strategy or depth de-escalation strategy, and this is published a lot of important clinical trial until recently, and the depth de-escalation abbreviation depth strategy is still class 2A recommendation, as no one answer, and still unsettled, and still dynamic question. So, and the depth strategy intensity or duration of a CHIP patient, and still not answered well. So, and this is our designed trial, tailored CHIP trial is targeting 2,000 patients undergoing complex high-risk PCI, like left main PCI and the CTO PCI, bifurcation region, 2 stenting, severe calcified region, and should require 3 stent, and the 3 region, and also diabetic and CKD patient, and the re-randomization, one arm is conventional depth clopidogrel plus aspirin 12 months versus tailored early part escalation using low dose ticagrelor plus aspirin, late part de-escalation, clopidogrel monotherapy, late de-escalation. We completed enrollment status in the 100% enrolled, and this result will be presented next year ESC meeting. So this is a summary, optimal depth strategy and cornerstone of management of ACS or PCI, consistently evolved to balance ischemia and bleeding risk. Still, one-size-fits-all approach would be not suited for optimal depth strategy for patient following ACS or PCI. Absolutely, we should require careful assessment, thrombotic and bleeding risk, and this should be tailored on the basis of the individual patient risk. And the depth strategy still unsettled or not yet case closed, especially for CHIP PCI patient, that will be provided more the data from the tailored CHIP trial. Thank you for your attention.
Thank you, DW. We look forward to seeing those results next year. So our final talk before we come to the panel is going to be given virtually, I believe, by Dr. Roxana Mehran on novel and future antithrombotic drugs in ACS and PCI.
Hello, and thank you for having me at TCT Asia Pacific 2024. Today, I'm going to present to you what are the novel and future antithrombotic drugs in ACS and PCI. Are there actually really unmet needs? These are my disclosures with research funding to my institution and some of the consultant work that I do. The determinants of antithrombotic therapy, which is the cornerstone of treatment in PCI, is very much dependent on the choice of treatment, the combination, the time point of initiation and duration, all of it determined by the patient's characteristics, clinical presentation, comorbidities, what other medicines they are on, and what kind of procedure they're going to go through. These are all coming between ischemic and bleeding risk and balancing this. This beautiful work was presented by our wonderful colleague, J.P. Collet, who should never be forgotten. We lost him this last year, which was a massive loss to the field, and his contributions will never be forgotten. The time course of bleeding versus ischemic risk is important. It's important for us to understand if we're going to control ischemic risk and bleeding risk after PCI, what's the time course? And a lot of it is very heavy within that first 3 months, especially in that first month, whether it's local ischemic events or even plaque progression and destabilization. Also for systemic ischemic events and bleeding, much heavy in the first 3 months. But if you look at all these curves, the local ischemic events become nil, stent-related events. But it's the plaque progression, destabilization, and outside of the stent that we need to think about, as well as systemic ischemic events that continue to lurk about, and as does bleeding. And so this makes the job of clinicians more difficult, and for us to find that sweet spot of the best ischemic protection without bleeding harm. And this approach of risk stratification towards tailored approach is something we need to do. And in some ways, personalizing antithrombotic and antiplatelet strategies after PCI. And we could do this with the clinical procedural variables and all the scores that are being made available to you all, but also guidance with both platelet function testing and genetic testing. And then, of course, understanding a little bit of also the bleeding and ischemic risk that have to do with these clinical, procedural, and scores for both bleeding and ischemic evaluation. And remembering that our guidelines are using some of these to tell us what to do with the different risk profiles, depending if the patient presents with stable or unstable syndromes of non-ST segment elevation or ST segment elevation MI. But I think it's really interesting to see how we have evolved the duration of dual antiplatelet therapy over the years, when we cared first and foremost in the early era, when the stents were new and we were just thinking about the focal effects and the local effects of stent-related effects, where we were only caring about thrombosis. And then we increased our and enhanced our stent technologies, and also introduced the potent P2Y12 inhibitors and started to see bleeding as an important area. And I think where we are today with the safer stent platforms, more nuanced understanding of stopping DAPT, as well as a better understanding of the ischemic profile of the patients and other very important treatments that are available, that we are now in a period of equipoise where we have the opportunity to think about these novel approaches of short duration of DAPT, P2Y12 monotherapy, and de-escalation. And so the strategies are here. Can we go to an aspirin-free strategy, for example? And I want to talk about these because the promise of that is reducing bleeding without increasing ischemic harm, especially in those high bleeding risk patients. Shortening that duration and going to an aspirin-free strategy. The factor 11 inhibition, though, is another interesting it brings you forward to like, what, we're going back to stacking therapies? But here, it's targeting residual thrombotic risk without increasing bleeding events. That's the promise, and we have to see that if this delivers. Well, let's first talk about aspirin-free strategies. There are major uncertainties about the use of aspirin for secondary prevention, namely major bleeding, especially GI bleeding, and intracranial bleed. And what we don't understand is what's the actual risk reduction on top of all of these fantastic agents we currently have, like high-dose statins, PCSK9 inhibitors, the GLP-1 receptor agonists, as well as the very important SGLT2 inhibitors and other heart failure therapies and other therapies that are really, really mitigating risk, as well as the potent P2Y12 inhibitors. And I think there's no question that we have moved now to P2Y12 monotherapy on so many levels. The global leaders started it all. We designed Twilight, but DAPT2 investigators that looked at patients with both stable and unstable syndromes, as well as smart choice investigators, as well as Tycho, where they really focused on acute coronary syndromes, and then DAPT2 ACS, where more patients were enrolled and combined with the DAPT2 ACS group to really, really understand what's going on, and then the ASCET trial. I can talk to you about the Twilight study that we designed, the only prospective double-blind placebo-controlled trial of ticagrelor plus aspirin versus ticagrelor plus placebo, published now 5 years ago. We enrolled 9,000 patients, randomized about 7,911 patients. And our hypothesis was that we would reduce bleeding, of course you would, but without ischemic harm. And that's why we needed 7,911 patients there. And we did prove that both primary and key secondary endpoint of death, MI, and stroke non-inferiority were met. Superiority in bleeding, non-inferiority in the hard ischemic endpoints. And I think this really changes the platform for us to think about it. Could this be for every patient? How do we measure this? How do we use this? Because in Twilight, we included both bleeding risk and ischemic risk. And so we evaluated this in Twilight ACS, over 4,000 patients. We showed that ticagrelor monotherapy was associated with significant reduction in bleeding without any increasing ischemic harm in ACS patients. And this abbreviated DAPT strategy and P2Y12 inhibitor monotherapy with ticagrelor gave it a class 2A recommendation in the European guidelines based on these data. As well as when you think about very, very important study of DAPT2 ACS, where this data did not support clopidogrel monotherapy. In fact, non-inferiority was not met. They did not meet the non-inferiority in terms of where they needed to go. And in DAPT3, which was an aspirin-free versus dual therapy strategy, where high bleeding risk ACS patients undergoing successful PCI were given prasugrel, then de-escalated to clopidogrel, or prasugrel upfront and de-escalated to aspirin. And what you could see that the patients who received no aspirin did have a higher hazard, in fact, of some of those CV deaths. So we need to think about that. For now, ticagrelor monotherapy is probably the way to go. The factor 11 inhibition is another area. This is another novel strategy. Dual pathway inhibition works. The rationale is this synergistic inhibition of both factor 10A, thrombin inhibitors, that was Atlas, remember that, and P2Y12 inhibitors, which actually are both working in platelet activation as well as coagulation. And in Atlas, there was a significant reduction. And in fact, in Compass, you remember, was fantastically positive. And in fact, for long-term dual action or dual pathway therapy has a class 2A, class 2B recommendation for patients with high bleeding risk. But the big question is uncoupling hemostasis and thrombosis actually possible? And I think this is really interesting because both are playing against each other. And in heparins, VKA, and DOACs, you know that we are leading with more bleeding no matter how you look at this. But with factor 11, when you go upstream in factor 11A or factor 11 inhibition, you may be having an uncoupling of hemostasis and thrombosis that needs to be tested. If you think about factor 11 inhibition, what's happening is that thrombin amplification is inhibited and that prevents the pathologic thrombi. But at the same time, the tissue factor pathway still is able to produce thrombin that allows for beneficial clots to be formed. So this idea actually comes about in understanding some evidence that this could be a target. In fact, in human genetic deficiency of patients with severe congenital factor 11 inhibition that happens in 1 to 450 in 450 Ashkenazi Jews, they have a reduced risk of thrombosis and rarely experience spontaneous bleeding. And if you look at some of the genetic cohort studies, the risk of thrombosis is twofold higher in subjects that have high levels of factor 11 compared to those with normal levels, and 40 to 90% lower in those who have reduced factor 11 levels. And animal studies have shown that factor 11 inhibition attenuates thrombosis in mouse, rabbit, monkey, and baboon models and doesn't increase bleeding. So as a result, there's been tremendous programs with small molecules, antibodies, all been set up investigating factor 11 inhibition, whether it's an antibody with the Ozalia, as well as the Lilac studies that are ongoing in the patients with atrial fibrillation, which we know their prior stroke, end-stage renal disease, acute coronary syndromes, which is the Librexia program, as well as the total knee replacement or arthroplasty that has been tested with several of these. And you could see the number of patients that are going to be enrolled. Importantly, just to talk about the small molecules, asundexian is the Pacific Phase 2 program that showed in AMI that on top of DAPT, this factor 11, without increasing bleeding, but there was a very important dose-dependent factor 11 inhibition, but no clear signal towards MACE reduction, and they're waiting to see whether or not they're going to do this in a larger trial. But in Librexia, the phase 3 programs are well underway for both stroke, acute coronary syndromes, and atrial fibrillation, about 50,000 patients, fast-track designation, and they're moving ahead with placebo-controlled trials in these 3 areas. So these novel strategies in ACS are here to stay. Could this be the better future, an aspirin-free strategy, especially when you have a high thrombotic and high bleeding risk patient? You could reduce the risk of bleeding without increasing ischemic harm. And factor 11 inhibition, well, the residual thrombotic risk may be achieved, but without increasing bleeding events. And this is very, very interesting to think about small molecules, antisense oligonucleotides, as well as antibodies with large-scale studies well underway. And so, are there still unmet needs? Well, I believe so. What about our patients with triple therapy, those who have surgery and recent PCI or residual thrombotic risk beyond antiplatelet therapy and managing that LV thrombus? And in the highest risk patients, in our dialysis patients, we really need more answers. But we want to thank you for your attention, and I want to really wish you a fantastic symposium. Thank you again.
Okay, we have a few minutes for discussion, and so I want to see if there's any questions either from the audience or from the panel.
Sorry, Karen, you have a question?
You have one?
Okay, gotcha. I would like to ask Dr. Park, in Taylor chip trial in the Taylor arm, you have a health patient undergoing clopidogrel only after procedure. Is there overlapping period of DAPT in the Taylor arm using clopidogrel monotherapy? Is there any combination of that, or just post-procedure, you just put on patient on clopidogrel treatment only? If you're doing so, did you check the PRU of this patient, because these are chip patients?
Yes, so, and the second question, we don't routinely use the PRU plate function test and the genetic testing, and without that, and the patient usually would be okay. So, and the second question is conventional arm, the aspirin plus clopidogrel, and the conventional arm, experimental arm, aspirin plus ticagrelor, and the low dose 60 milligram. At 6 months, we're gonna change it clopidogrel monotherapy. At the time of the change, we do clopidogrel loading. In the 600
Okay, so that's after 6 months step with aspirin and low dose ticagrelor.
Yeah, right.
Okay,
right,
thank
right.
you.
Sorry, thank you. Excellent talk. Can I just wonder, in practical terms, how do you assess bleeding and ischemic risk? Do you really use these scores? There's so many types of scores for ischemic and then for bleeding risk. Are you going to use which particular favorite scores do you use in everyday practice when you have questions? Those cases that you presented earlier on, those difficult, complex PCI cases, do you actually measure the scores for bleeding and scores for ischemia, and then decide how to move forward?
In our daily practice, we don't have enough time to calculate the risk score. Of course, there's many risk scores, but in this post-hoc analysis, we try to validate the results in several different scoring systems. Thus, I believe scoring system is as good guidance to predict, to guide us to modulate intensity or specificity of antiplatelet agent. But daily practice, we don't have any habit or system to apply such kind of complicated scoring system to daily practice.
Yeah,
but I think it is helpful.
I mean, I would also add, I mean, the nice thing about the HBR criteria, the bleeding risk criteria, you don't have to calculate a score. There just are, 10 or 12 criteria, and they're pretty, pretty common sense, and you can make a little card or something like that and have it on the wall, so it's not so hard. But I think clearly, we don't normally calculate all these scores because they are a little bit complicated, but also because, it is. We still have so many different regimens, and so I think that from a practical standpoint is one of the answers. I want to just open up for the group here for one specific question. So let's make a very specific scenario or question. So how many of you are routinely stopping aspirin at 1 month or 3 months after a PCI in an elective setting, and just switching to single antiplatelet therapy with a P2Y12 inhibitor? I just wanted to show hands across the panel of anybody who is doing that in their routine practice.
Routine.
So Dr. Kim, thank you. Well, I'm glad you are, because you wrote all the papers on it. But I think that to me is interesting. And it's reflected, our guidelines are slow to pick up on it. And I would like Dr. Kim maybe to comment on why is the uptake of what seems to make very good sense, has incredible data behind it, why is it not so good in clinical practice? And Tullio, you?
So I would like only to expand this issue. So when we talk about P2Y12 monotherapy, de-escalation, should we make a distinction between ticagrelor and clopidogrel? Or, we can talk in general of P2Y12 monotherapy.
I think aspirin is misunderstood as a weak agent. I don't believe it. It is non-selective drug. It inhibits cyclooxygenase that controls the synthesis of various kinds of prostaglandins. Some of them thromboxane A2, but the other prostacyclin and prostaglandin HCG all of those prostaglandins are involved in not only thrombosis or bleeding, but also the maintenance of tissue integrity, such as mucosa or brain vessels. Thus, I believe in comparison with such kind of non-selective drug, clopidogrel is a very selective drug, just focus on P2Y12 receptor. That's a fundamental difference between two drugs.
In this point, I would like to ask one question. It's free from the lectures from Cohen and Kim. You prefer to use of beta-12 inhibitor monotherapy, but for Kim, he would prefer to use clopidogrel. The Cohen, you prefer to use ticagrelor. So how about the ticagrelor in HBL patient? How about the clopidogrel monotherapy in so complex PCI? So who is the winner?
I mean, I think that, the data, we have more data, and Dr. Kim just, finished the TPAS study, which was also with ticagrelor, so he's not just a clopidogrel guy, he's equal opportunity, I think. So, the advantage of ticagrelor, obviously, is that it is, not subject to genetic polymorphisms, and it is more uniformly effective. The main disadvantage is it's twice a day, and also that it's more expensive, at least in our country. And so there are, things other than the biology, I think, that are.
I'm Japan from Yokoi, Japan. In Japan, that in chronic cases, now 1 month stop the DAPT, move to P2Y12 day. We have a low dose prasugrel in Japan, only Japan. I asked to Dr. Park, your protocol modified the ticagrelor, low dose ticagrelor. Choose low dose ticagrelor. We Japan, we choose the low dose prasugrel. I think compared with the US and the European country, our Japanese Asian Pacific field have to use low dose P2Y12 inhibitor potent direct. How do you think that?
I think East Asian population has a different profile for bleeding and the ischemic risk, but still, I think 3.75 not available in South Korea, and always after presentation of a Japanese clinical trial, some argue how can you apply the real practice of 3.75 is not available beyond Japan. I think that is still the debatable portion, but frankly speaking, the low dose would be okay for the East Asian population.
Yeah, thank you.
I think we need to finish up so we can get to the next session. I want to thank everybody for their participation and for their active questions, and clearly there still are more questions to be answered. Thank you.